Well, welcome everybody to this series in our series of SIMUL8 webinars of how people are using simulation effectively in healthcare. And I'm absolutely delighted that we're going to be able to present this subject to you today. My name's Claire Cordeau. I'm the Executive Director of Health and Social Care here at SIMUL8 Corporation. And I'm with Cheryl Davenport, who's the Director of Health and Care Integration at Leicestershire County Council. We're here to talk about simulation to evaluate great care, otherwise known as SIMTEGR8. This is a very interesting project which was a result of a collaboration between Leicestershire County Council and Loughborough University, looking at the evaluation of the Better Care Fund intervention on emergency admissions. And I'm going to hand over to Cheryl, who's the Director of Health and Care Integration at Leicestershire County Council. I'm so pleased, and thank you so much, Cheryl, for joining us today to share your experience.
Lovely, thanks, and good afternoon, everybody. It's a really good opportunity to share with you the work that we've been doing in Leicestershire. I'd like to start first with just a bit of an overview about the Better Care Fund. For those who may not be joining this call from the UK, the Better Care Fund is a pooled budget between NHS organisations and local authority partners, and you'd find a Better Care Fund in all parts of England operating since 2015. It's a pooling of a budget to enhance integrated care, to get health and social care to actually develop new ways of working in a joined-up manner. And it's measured through a number of metrics, including reducing hospital admissions, improving hospital discharge, and the benchmarking that goes on nationally is against these core metrics, and we'll come back to that in due course. I think it's also fair to say that there's a high level of political expectation and scrutiny on this work. This is about shifting funding from acute sector spend and moving it into community-based care, and demonstrating that that is a value-added way of working, and that costs can be reduced on the acute sector by putting in place integrated care in the community. So measuring the impact of whether this actually happens in reality is one of the key challenges of running this type of programme. So just to explain a little bit about how locally we've responded to that national policy context. Here in Leicestershire, we're part of a larger geographical area which is covering Leicestershire County, the city of Leicester, and a smaller county called Rutland, and together those three geographical areas are working on a programme called Better Care Together. So that covers a wider geographical boundary than just Leicestershire itself. Within that geographical area, we were asked to look at reducing emergency admissions to hospital by 3.5%. That was in line with the national target that I mentioned earlier. And so we were keen to implement a number of new interventions in the community that together would deliver that 3.5% reduction. And with that, we were keen to establish a way of measuring whether we had been effective in that work. And so at the beginning of our programme, around about Christmas time 2014, we were looking at how could we collaborate with other partners to come up with a methodology to evaluate our work. And that was when a number of conversations began between the four partners who've been involved in this project. So Loughborough University, which is a university in a town just north of Leicester. Healthwatch, which is the patient representative patient voice group locally, Healthwatch Leicestershire, an independent body that's there to represent patients and their views. Leicestershire County Council, which is one of the key partners to the Better Care Fund, and then SIMUL8 Corporation, who had technology that could help us model the impact of our work. Together we formed a partnership and applied for a research grant at Loughborough University, and we were successful in that grant, and that allowed us to undertake the project for a one-year period to evaluate those 4 emergency admission schemes. And the timing of the project was to make sure that by the time we got to December 2015, we could take some decisions about our services based on the outputs of this evaluation. And so we wanted very much that we would have completed that work and had a report of that work in time for that to happen. So our local context was one of committing to that independent evaluation, and from what we understand, we are one of the first places in the country to have undertaken that work in 2015 at the beginning of the Better Care Fund. We set up some infrastructure to support this project, which included some resource to undertake the evaluation, and we had a researcher from Loughborough University working with us on a part-time basis, as well as resource from SIMUL8 Corporation. We put in place a small programme board and an advisory board. I'll tell you a bit more about them later on. And then we adopted a methodology based on some previous work on simulation that had been done by partners to test these pathways. In particular, we wanted to look at how the pathway was operating within the healthcare system. Was it effective in avoiding an emergency admission? But we also crucially wanted to understand what the service user's experience was of using the service. And to supplement the work that we did in this project, we also undertook some clinical audits. And we thought that that was really important because we wanted to test if the referral into the service had been appropriate. Was this patient a suitable candidate for the service? And therefore was the avoided admission in line with that clinical criteria? So by taking the SIMUL8 modelling and the clinical audit together, we could make some assessment of the success or not of that methodology. So to summarise the purpose of the study, we were keen to evaluate how emergency admissions to hospital could be reduced, and we were also keen to look at how we could improve the patient journey, particularly as we were implementing 4 completely new interventions, and an element therefore of experimenting with those interventions and seeing how they could be improved for the future. So just to talk you through the 4 interventions that we evaluated. In our Better Care Fund plan, we were focusing particularly on older people, people with long-term conditions, and people who had urgent care needs in a community setting. So the interventions you will hear about are targeted very much to those groups. So the first group of people we were looking at were people who were being admitted to hospital primarily because they needed geriatric opinion or diagnostic workup with a geriatric opinion. GPs were in a situation where often the only way to get that level of intervention was to admit the patient to an acute bed for a period of days. And so we identified an opportunity to provide a service outside of the acute hospital where these patients could go for a 2 to 3 hour outpatient appointment, but crucially one that would be completed by a multidisciplinary team and would include a geriatric opinion and would include a number of other diagnostic tests. So the older persons unit, which is based in a smaller district general hospital or community-based hospital, was based on a ward there where the multidisciplinary team could take referrals on a Monday to Friday basis and undertake that comprehensive assessment. Within this model, we put in place an advanced nurse practitioner and a consultant geriatrician as the 2 kind of key clinical decision makers. And referrals for this service could come either from GPs directly, from the ambulance service, the East Midlands Ambulance Service, or even from the emergency department. So the second service was about some crisis response in the community. So in our community settings, we have community nursing teams and community social work teams operating in their usual way. We had, however, started to develop a crisis response service that would actually attend to a patient in their own home within a 2 to 4 hour period, and that would be a combination of either nursing and or social care support. However, there was a missing element to this service in that the nursing component didn't extend into the overnight period, and we identified that there were a cohort of patients who actually could be cared for at home in a crisis for a short duration, perhaps 2 to 3 days. If an overnight nursing component was added, there would be an avoided admission to hospital as a result. And not only would you avoid the admission, but you'd avoid all the complications of then having to discharge them from hospital. So our second intervention was to introduce overnight nursing into that model so that it really provided a resilient 24/7 cover. And so this went in 7 nights a week from 10 p.m. to 8 a.m. and was not seen as a separate service, but as an adjunct to the existing daytime services. So that was the second service that was evaluated. The third service is one which was in place in some other parts of the UK. This was a service whereby we had a large number of patients who, following a fall in the community, were generally conveyed straight to hospital by the ambulance service. But a number of those patients, a significant number, actually didn't need to be conveyed to hospital. And this intervention involved training our paramedic staff through East Midlands Ambulance Service to undertake a consistent falls risk assessment tool, and then to determine if the patient didn't need to go to hospital but perhaps needed that crisis response that I mentioned earlier, that could be accessed very quickly and the paramedics could hand them over in the community and the paramedics could get on to the next acute emergency. And so that pathway we had seen operating in other parts of the country, and we wanted to replicate it in Leicestershire. So that was the third intervention that we looked at. Okay, so the fourth intervention is again based on something that was being introduced nationally in 2015, and this is around the availability of GP services, primary care services, 7 days a week. And to explain, this is not about everybody in the population being able to access their GP on a Saturday or a Sunday. It's about having something in place on a Saturday and a Sunday for specific vulnerable groups of patients. And our clinical commissioning groups, the groups that commission and organise our NHS services locally, they worked with our local primary care services in both the east and west of our county and undertook a number of pilots of 7-day services in the course of 2015. These were very much testing these models and were happening at slightly different times throughout the year. So in terms of this service, they weren't running all the way through 2015, they were stop-start. Okay, so moving on then, just to tell you a bit about the governance for the project, we had a local project board comprised of the partners that I mentioned at the beginning. We had the researcher from Loughborough University. Loughborough University was responsible for the academic oversight of the work and also for producing the evaluation report. Healthwatch were responsible for running patient experience workshops and actually testing the simulation models with users of services. For Leicestershire County Council, I provided the Senior Responsible Officer senior support to the project. I also worked with the stakeholders across our health and care economy and also with the project leads for the 4 interventions that I mentioned. I was the link to those services. For SIMUL8, we have the simulation modelling support, resources and training, and obviously the use of the modelling tool itself. And all of the partners contributed to project management, administration, communications and dissemination. And we set up a collaboration agreement for this project so that looking ahead, when we got to dissemination, we would have an approach, a joint approach to that. And clearly this webinar is part of that dissemination approach. So along with that, we brought together a group of people who would be our sort of external advisory board. This was a great development, really helped us with the work that we were doing. It allowed us to get a sense check and some challenge from people not involved in the day-to-day work in Leicestershire, but who could add value to the critical analysis of what we were doing, and also add value to the approach to dissemination. So we were very fortunate to get the East Midlands Regional Lead for the Institute for Health and Care Excellence. It's a national body within the UK that is about the evidence base for health and care. So we had the East Midlands Lead join our advisory group. The Better Care Fund National Policy Team also sent a representative from their group to our advisory group, which again was a really excellent development, and also has helped with the dissemination and interest in this project. We had an academic advisor who's involved in similar work at Swansea University. We had a local GP who joined our group as well from the West Leicestershire area, and we also had the head of research from Leicestershire Partnership Trust, which is the local provider of community services. Clearly a number of the services that we evaluated were from that organisation. So that panel met about 4 times during the course of the year to look at the scope of the work, the results of the work, and the dissemination approach. I mentioned earlier that we are undertaking some clinical audits in support of the work that we're doing. We do have some other evaluations across our programme. So the 4 emergency admission schemes that I mentioned are only part of the pooled budget. We have a £39 million pooled budget here in Leicestershire for this work. So we've got a range of other developments going on. And within that, we've got some other evaluation, external evaluation. SAME and ROSPA are 2 elements of academic evaluation for our falls prevention programme. And we also have something called local area coordination, which we've been piloting for about 9 months. And this is essentially community development workers working with vulnerable people actually out in local communities, helping them set independent lifestyle goals around improving their health and well-being. So we are evaluating those the effectiveness of local area coordinators later in this year. So just to give you a flavour that we have a number of other evaluations ongoing. So what we're going to do now is take you through what we did in terms of developing the simulation models for the 4 emergency pathways, and also how we ran the workshops. And I'm just going to hand over to Claire now, who's going to take you through how the models were constructed.
Thank you very much, Cheryl. So I'm going to focus particularly on the night nursing service simulation that Cheryl mentioned earlier, the overnight service. And what we were looking at with the simulation is a typical simulation, which is how's the service working now, what's the impact of the change, and what's that telling us. And we were very focused on our stakeholder workshops and engaging patients and carers in the simulation model in order to get that full impact and understanding for the evaluation. So the purpose of the workshops was to evaluate the key question about how emergency admissions to the hospital could be reduced, and also to help improve the patient journey through those new interventions. And the one I'm going to particularly talk about is the night nursing one. So this is the before model, and you can see the process flow here from the patient who has a need through to the referral to triage, presentation at the emergency department, the triage of the patient, and either an admission at that point or a discharge. The discharge can be through the single point of access, and you can see how that works itself through. So that was the current phase of how the existing service works. And we built that into a simulation using the data from an audit that had been carried out to look at the volume of activity, how it worked itself through, the capacity of the service, any bottlenecks that were happening. And so the audit was telling us that there were 1.2 patients a night, there were over 2 months, and we saw the number of patients over 6 months. So we thought that was a reasonable basis on which to base the kind of baseline, if you like. And 95% of patients were admitted from that point. Now the after and the new service was that at the point of a clinical need or social need for the patient would be referred through to the single point of access, who would then refer them on to the night nursing service, and they would stay with that service for a couple of nights, and we had some interesting results about how that actually worked, and in some cases people would stay, the plan was that people would stay for 3 nights. In actual case, in fact, they stayed for slightly more, but that was how the new service would work. And this was the basic simulation that we set up to talk to people about how the system worked and whether they recognized that that was an appropriate reflection of how the new service was working. And you can see there that 90% of that group then went to night nursing. So we started with that simulation and took that to our first stakeholder workshop in order to get the feedback from people, and we had a range of people there, from Healthwatch to the nurses who were running the service, to the emergency department, to commissioners, so that everybody could look at the simulation to make sure it was a reasonable reflection of what went on before, and then to understand how it was working afterwards. And that was fascinating, actually, because the result of showing the simulation allowed people to talk about their experience and actually to share their experiences between each other. And it was interesting how, whilst the system seemed to be working really well, that different parts of the system didn't quite see the impact that they were having. So the night nursing team hadn't necessarily appreciated the real difference that they were making to the service. So we made some amendments to the simulation following some of their feedback, and in particular, some of the things that I particularly remember coming up was about the referrals from the single point of access, understanding the time at which patients were referred to that service, and what happened to the people where there was not enough capacity within the service to be dealt with. And that was something that actually had been hidden from the understanding of the people within the service, because they just never got to see them. And it also gave some useful insight into where more resources might be needed to be even more successful. Now, from that, as you can see from the visualization of that flow, whilst it meant something to the people who were involved in it, it didn't necessarily mean anything to people who might get that service, who were wider stakeholders and who were patients. And so we changed the front end of the simulation to help to tell that story a bit better, because part of what we wanted to do was to get that real engagement with wider stakeholders about what the new service was about, how it might affect them in the future, and also we wanted to get patient input into that simulation. So you can see we were trying to build a more visual description about how the current system works and then how it would work in the future. And with the workshop, the important thing was to try and get some face validation as well as some numeric validation of the simulation. Was it reflecting reality? And also to ensure that we triggered the sort of discussion that we wanted to get, the sort of insights that people had about how the system was working. We wanted them to be able to talk about the problems that they might be having, where they thought things were working well, and how their improvements might be made. And of course, for every stakeholder, there's a slightly different view, and the model really did help us very much in understanding that in a lot more depth. And it's probably important to say at this stage that Loughborough University research interest in this is very much about how you can use models to generate that kind of insight, to have those sorts of discussions, and what that brings out in a way that perhaps if you've seen the system or discussed it with a different format, you might not have got. And that was particularly what Loughborough was bringing to their expertise in drawing out those discussions, was bringing to the workshop and helping us to identify as we worked out what people were saying. So one of the things that we learnt, and particularly Healthwatch were very helpful in identifying this, was that just showing a picture like I had before with some people running through it was great, but it didn't necessarily speak to the patient. So I'm going to jump over to the actual simulation now on the screen to show you a bit more what I mean. So this is the live simulation, and I'm just going to set it running now. And what you can see is we've got the activity, people coming through. This is the before, they're attending services, and then they're coming out at the end. And we've got an after, which I'll show you in a minute as well. So we were comparing the two different systems. Now the thing that we brought in, which in addition to engage the insights of patients into this, is the patient story. So we took a typical patient and we flagged up when they'd arrived in the service. So you can see we've got the time, it's 5:05 on Friday the 20th of February. The patient has been selected, and we're going to be comparing their journey through the before system and the after system, and we're talking about Howard Clark in this particular case. So as we run through the simulation, in the before system, Howard would be identified with a medical need, go through the normal challenge and be referred to the ambulance service. In the after, he would be referred through to the single point of access service, and this is the picture of the after, where you've got the night nursing service with a roving team of nurses, and also a virtual bed where you've actually got somebody who's in the home all night. So you've got two parts of the service that you could access. So you can see that the single point of access is able to refer people through there, and then you've got the rest of the system acting as normal. Again, in the after, Howard is referred to and attended to by the night nursing service, and the roving team is going to check on Howard during the night. As I said before, this could continue for 1 to 3 nights, although sometimes 4, or until another service. In the before, at this point, the ambulance service would decide whether to bring in an ambulance, and from that point, if there are concerns, then Howard would be taken to the emergency department, and Howard would be assessed again for treatment at the emergency department. And you can see we're picking up the time here as Howard moves through his journey, and then you can decide whether Howard should be discharged, in which case he actually was in this point, or somebody else might have been admitted at that point. And at that point, for Howard in particular, he's referred to the unscheduled care team until the planned care team can deliver care, or no further care is required. In the after, the new scenario, how it is attended to by the night nursing service, and again that can continue until it's needed, as long as it's needed, and up to the 3 nights. And if he still requires more care, he's referred to the unscheduled care team until no further care is needed, or he's in the planned service. And then in the before implementation, you can see that we've measured the amount of time that Howard needs to, it might have no further care, and can compare that with the after. So we'll just run that through to the end, and you can see here that we're picking up the key results about how many patients are coming into the model, how many admissions in the before versus how many admissions in the after. Now we wanted to show it in this way because it helped to get that engagement, particularly with people who weren't necessarily used to the system and had different views of the system, depending on whether they're a patient or a clinician or a manager, and everyone's got a slightly different picture. And it really enabled us to get the feedback back that we needed to understand whether this was being a successful service or not. So I'll just run that through to the end quickly. And what you can see is the amount of time that this has taken to get from one place to the next and compare it. So I'm going to hand back to Cheryl now to tell us the rest of the story.
Thanks very much. Just wanted to go back to the overall methodology and explain how we used it to generate our outputs. So the methodology was designed to create a stakeholder and service user discussion about 4 main things, about the model itself and the pathway, about whether in reality the pathway was operating in the way we expected, and also about metrics and data. In particular, in the simulation you've just seen, capturing the data in real time, or as near as real time as possible, and plugging that into the model so that you can run the impact of it through the simulation is absolutely key to understanding how the system is performing. So the methodology allowed a discussion about those aspects, but the discussion was targeted to 2 main things: to identify any issues with the service itself, and then to seek some resolution of those issues. And I think through the workshops that we held, there were probably 3 things that we considered. Were there any issues with the service itself? Were there any issues with the system around the service? And so by introducing this new pathway within a complex health and care system, was it actually standing up and being able to run consistently, or was it being were there any barriers to it running consistently because other parts of the system just weren't working well in tandem with it? And then the third thing was really around the measuring of the impact, you know, in terms of the data and the metrics and what we were trying to evaluate. Did the discussion across stakeholders and service users throw up any particular issues around measuring impact? So moving on then, just to look at where the methodology overview came from, Professor Stuart Robinson at Loughborough University had already done some work on lean and simulation, and there's previous work called SimLean that he had been focused on elsewhere, and we adapted that SimLean approach to this approach, which was conceptualize the model, develop the model electronically, and then hold 2 types of facilitated sessions, one with stakeholders, those being the professionals involved in the delivery of the service and the wider healthcare system, and then one with users, service users, patients, a workshop for them. So the methodology was really around those 4 components. We held a number of workshops for the purposes of the 4 interventions. We held 4 stakeholder workshops, and in the end we only held 3 user workshops, and the 7-day services in primary care didn't actually have its own stakeholder workshop, simply because of some difficulties that we experienced in accessing that cohort of people, and I'll explain a bit more about that later. So this just shows the number of workshops, the topics, and when they were held. So using the before and after maps, I mean, very much about getting a discussion about whether this was accurate. So the project lead worked with the SIMUL8 expert to design an initial process map, but the stakeholder workshop was used very much to refine that. And yes, the maps were mostly accurate in the heads of the project leads, and then generated in the electronic version with the SIMUL8 support. But some changes were needed, and in fact it was only when all stakeholders came together that you got the best service map within the system, and that was confirmed and challenged by all the people in the room. The other byproduct of that, an unexpected byproduct of that, was the work that we did on changing the front end of the simulation, so that this technical view, if you like, which we started with, a sort of common, if you like, process map, then went through a second iteration into a more sort of descriptive version of that map that could be understood by more people. And then eventually, using the feedback, particularly from service users, we moved on to more of a storytelling version of the map, and that included the sort of symbols and visuals that we saw there on the simulation a few minutes ago. So just moving on to the next slide, I just wanted to show you the visual display and how we move from the technical really to the patient front end. So by using, you know, very simple symbols around sort of ambulance, conveyance, telephone, somebody's home, a picture of the hospital, etc., and plotting that into a much more user-friendly set of symbols, we could take the technical process map and create something that was visually more engaging for a wider range of stakeholders. This was not an intention of the original project to do this piece of work, but once we'd taken on board the feedback, particularly from service users and from Healthwatch, we actually ended up with versions of each process map that were in the user-friendly sort of layperson's language, and those have become the ones that we tend to use irrespective of the audience. So this was a very helpful and unexpected byproduct of the work. So we'll just move on to the next slide. Just wanted to run through some of the issues that we covered and issues that came to light in the course of the workshops. A lot of issues around metrics and data, so the quality of the data, the source of the data, the reliability of the data, the regularity of which data was being generated from these 4 interventions. This was all very much thrown into sharp relief by doing these models, and where the outputs of the models looked very strange or were worthy of challenge in terms of, have we really got that number of people? Did we actually achieve that throughput? What is the data telling us? Led us to really homing in on some of those data quality issues. Also, the suitability of the metric or the KPI, the performance indicator that was being used, could also be challenged by using these models, which was very helpful. Some of the other issues were more practical around things like referrals. Were we getting the right referrals? Were we getting enough referrals? Should we allow self-referrals? And if we did that, would the service become overwhelmed? The modelling allows you to obviously put in data to show a what-if scenario. What if we had 20% more people if we offered it via self-referral? And we also looked at things like other services that may not have been included in the original process map. Were there other points of handover, particularly at the end of this pathway, that we hadn't thought about? And we also looked at things like the relationship with patient care plans and the differences in geography across the county of Leicestershire, do these services operate differently in different parts of the county, because actually the infrastructure is slightly different in a geographical area. So this allowed us to start to generate some solutions. I haven't gone through all of the solutions here, but I've given you some examples. So we looked at what we could do to improve the collection of data, particularly from the single point of access, which is the telephony part of our community services. We looked at the problems in collecting some of this data individually and collectively across the pathway. So if you think about the falls non-conveyance and the risk assessment tool that we asked the paramedics to complete, how we're capturing that data, and then how we're capturing data from the community service they might be handing off to, and generating something that's sensible across two sets of data. Those were the sorts of issues that brought to light. And then there was issues about publicising the 4 interventions to professionals, to patients, getting some feedback about how effective that had been. Were GPs really familiar with how to use these alternatives to hospital admissions, like the older persons unit, and what feedback were we getting about that, and was that a barrier to getting a consistent use of the pathway? So I think it helped really to shape that discussion with stakeholders. We had already identified a number of issues with the 4 interventions by the time these evaluations took place, and so anything that came from this evaluation work was able then to be plugged straight into an existing action plan to improve the way the pathways worked. So just moving on then, I just wanted to touch on metrics. We were collecting some metrics through our step up, step down dashboard, which was looking at avoided admissions, but we felt, having looked at this work, that wasn't the whole picture, and we might want to look to some new areas of metrics. In other words, where people were handed off into the healthcare system, what was the sort of point of discharge for them, what else could we gather from that, how much time they had spent in different parts of the pathway, as well as whether an admission had been avoided. And just on to the next slide, we also wanted to look at demand failure. So if people were actually being moved around the system but not actually in the right pathway, not finding the right care in the right place, these are the sorts of things that would give us a better indication of whether integrated care is actually working. And then finally, we wanted to work with Healthwatch to consider whether there were other patient satisfaction metrics that could be used. One of the difficulties that we have in our current patient experience measures in the NHS is that they tend to measure a single service. So what did you think of your GP experience? How would you rate your hospital experience? This is not a measure of integrated care across organisational boundaries, and so we would like to start to consider what those metrics might become. We haven't conquered that in the first phase of this work. This is something we will be looking at in a second phase, and we asked Healthwatch to ask patients through the user workshops what would be usable metrics from their points of view and from the experience of Healthwatch in other work. This slide shows the sorts of things that patients, as you might expect, will be looking for in measuring their experience. What we'd like to do next is think about how we measure an experience of integrated care as an alternative to hospital admission. And I think this is going to take us in the direction of, how was your care coordinated across agencies, or perhaps even you didn't notice it was being coordinated because it was being done so effectively. And some of these sort of housekeeping and hygiene factors still need to be in there, but we would like to get to the real nub of what did that integrated care feel like for the patient. Did they feel confident not to be cared for in a hospital setting, but to have something else in the community? So just aware that there are quite a number of different tools that we can use to measure patient experience. I'm not going to go through all of those today, but we will be considering those and how best to do it. One of the problems that we found with this particular project was some of the patients were really quite acutely unwell at the time of receiving the service, and it wasn't appropriate to be capturing this information at the time, and therefore we were relying on doing it afterwards. And again, that led to some difficulties then in capturing information in the way that we would like to do so. So there's a lot more work to do here, I think, and be useful to get any feedback people might have on the call about other experiences with this. So just to come back to the outputs and what we have really learned and where we go next. In the workshops, we managed to measure how much of the discussion was about the simulation model, the service and the patient pathway. And this slide just shows the proportion of time that was spent on those elements, which does show that the use of the simulation model prompted the discussion. And we feel, again, coming back to what Claire said, that we've demonstrated the use of a simulation tool generates problem solving across organisational boundaries. There were some lessons that we learned from the user engagement. Again, I won't go through this in detail, it's the next slide, but the difficulty of engaging with frail and elderly people at the time, and also their carers. More work needed here to consider the best approach in phase 2. Finally, just wanted to turn to how we applied the findings. So we had an existing action plan for our schemes. We were able to take immediately the findings and recommendations from this evaluation, from the workshops, the barriers, the issues, the possible solutions, and overlay those onto our existing action plan and start to work through them. We were able then to engage our acute trust, that's the University Hospitals of Leicester, UHL. We presented to their exec team to talk them through what we'd found about these pathways. The acute trust is a hugely important partner in this work. We are trying to keep patients away from their door. By agreement with them, these patients need to be dealt with elsewhere. So they wanted to see how well or not these pathways were working, and we were able to use the findings for that session with their exec team. And then we've also been able to make some decisions about the future service. You know, based on the findings of this study, should we recommission these services? If we did so, would we change anything? What should the model and design look like for the future? And all of that was considered in the period between December and March, helping us to adjust any investment for this financial year. So that's you know, evaluation into practical commissioning intentions, which I think is really important. So we're now on to phase 2 of this work. We're literally just about to start in August. We have a second set of money that's come from our National Better Care Fund team within England. They've allocated some money to us to do a second phase. We have 4 more schemes that we're going to evaluate. But in parallel with that, we've started the dissemination of our phase 1 work, and so this webinar is part of that today. We have also held a face-to-face seminar here in the East Midlands for my Better Care Fund colleagues who work in other parts of this geography. And we will then be disseminating through a number of other routes. So if we move to the next slide, you'll see that we've got a number of other dissemination routes planned through Healthwatch, through Health and Wellbeing boards, and through academic networks. So that plan is underway. The learning that we've taken from the first phase is being embedded into the second phase, particularly around user engagement. And finally, we have a website that we're currently testing where we're going to place a lot of the resources about this study. There will be handbooks and models that you can use on the website. And so the next slide just shows you where you can view those. And should you wish to follow up with us after the call, there are all our contact details also on the slides. But I'll end there because I know we want to leave some time for questions.
Cheryl, thank you so much for taking the time to explain so clearly the project. It's been a fascinating, interesting and really rewarding project for us to have been involved in. It's produced lots of questions as well. So I'm just going to read out some of the questions that have come in. Cheryl, if you don't mind asking them, just to let everyone know, if we don't get time to answer all the questions, then we have a LinkedIn site, Simulating Health, and Cheryl's very kindly agreed to do a question and answer. So do please keep the questions coming if you've got them, and Cheryl will answer them afterwards if we don't get to them in this session. So the first question then is, appreciating that this was an evaluation and not a modelling method, is there a way of using the same tool to model the potential impact on admission rates?
Yes, so if, for example, another part of the UK perhaps had a similar pathway like the Falls pathway and they hadn't yet implemented it, they could replicate the same model and test it for their own health economy. Having said that, of course, all health economies are slightly different in terms of the baseline of services that are already in situ. So what we've, I guess, provided is a starting point for that. And in terms of the rest of the work in Leicestershire, we are looking to replicate the modelling tool with other pathways in our local area. So I think there are two potential routes you could go. Replicating what Leicestershire has done in your local area, or extending the use of the tool to a completely new pathway using the learning that we've undertaken. And I think the website will give you an opportunity to run a simulation using our 4 pathways, but as I said, it will depend on your local circumstances as to how replicable those results are.
Thanks very much. A second question was, did you struggle to recruit a community geriatrician, or was that a role that was undertaken by the acute geriatrician?
In our local health economy, we have some geriatric posts that are shared between the community and acute trust. And so we were able to source the geriatric support actually from the community trust end of the team. But yes, there are, I know, recruitment problems generally with this specialty. But we have been fortunate to have a community geriatrician in place from our community trust. But they are working in tandem with the acute and have a number of shared posts, so that made it slightly easier.
Great, thank you very much. And there's another question around staffing as well. Somebody wanted to know, because you use EMAS to do your Falls Rapid assessments, does that mean you didn't need a specific Falls nurse as well, or did you have that role in place?
Sorry, just to take that question again. Sorry, I just missed part of it.
So you used the East Midlands Ambulance Service to do the Falls Rapid assessment.
Yeah.
So did that mean you didn't require a specific Falls nurse as well? Do you have one of
so yeah, all of the EMAS crew have been trained and continue to be trained to deliver that tool. We do have Falls clinics in the community. So if somebody has had a previous fall or is at risk of falling again, we have a 6-week program which is run actually by physiotherapists and occupational therapists in the community to prevent future falling, but we don't have fall specialist nurses at present.
Great, thank you very much. A simulation question now. Somebody wanted to know if SIMUL8 is a deterministic model. Cheryl, I think I'll take that if that's okay. It's not. It's a stochastic model. So what we can do is to have a number of distributions which reflect the variability of the way in which individuals use services, the time they take within the service, the arrivals in the service, and so we can run a simulation multiple times and sample from those distributions, so we get confidence intervals, and we can look at the mean of that for our overall results. So it makes it a very robust tool, but the person who asked that probably noticed that I only ran the simulation once. So we only had one run of that, and it was really just to illustrate that. But Simulator is a discrete event simulation tool. So a further question is that whether the night nurse service seems to be hugely successful. Was it also cost effective?
Really good question. So one of the things that we found from evaluating the night nursing service was that a number of patients who were being referred into the service were patients who were at the end of life, and actually for whom other services were available on a 24/7 basis. But these patients were not getting as rapid a response from those services as they were from our new night nursing service. And therefore the cost effectiveness analysis has been about the fact that there are already some commissioned services for the end-of-life cohort of patients. There are also some patients who have other physical health needs overnight for whom this service, the night nursing service, was the targeted group. And because we had two sets of people trying to access that service, which we didn't expect, at times the service was full, the 4 beds, the 4 places were all being used, and some GPs were experiencing difficulties getting patients into that service, which was exactly not the position we wanted to be in. So the cost effectiveness of the service has been re-evaluated on the basis of ensuring that the end-of-life patients receive the pathway that they should receive, and that becomes responsive to their needs. And then the cost effectiveness would come back into line in terms of the other patients with other physical requirements that actually we do want to be targeting with this service. So it did lead us to quite a useful analysis about initial thoughts were that we needed to increase the night nursing capacity because it was getting a number of patients turned away, but on further investigation we found that this was due to the overloading of the service with end-of-life patients. And so for commissioners particularly, we wanted to show the cost effectiveness of this service to the targeted cohort, and that they're not paying twice for patients who need that overnight care. There are very specific needs of end-of-life patients that need to be rooted in that way with that particular expertise. And so there's been a little bit of an unravelling, and calculations have been underway there to look at what the actual demand for the other physical cases for the night nursing service will be into the future if the palliative care and end-of-life patients are routed through their usual channels. So yes, initially you can see that putting in night nursing is not the cheapest option. On the other hand, you're preventing an acute hospital stay and all the discharge costs that come at the end of that stay. And I think in terms of avoiding a hospital admission, it's been the most effective of the services we've had clinically. So clinical effectiveness and cost effectiveness have both been reviewed in the course of doing this study.
Thanks very much. I can't stop the questions from coming, which is fantastic, Cheryl. You've really, really obviously spoken to people in a way that really chimes with the things that they're wanting to ask locally. So I'm just going to take one more, and I think we will definitely have to take you up on your question and answer afterwards, so that we make sure we get all of these answered. But the question I'm going to ask you, just to finish up with, was there much resistance in respect of changing the focus of the night nursing role from a traditional model?
So I'm not sure if the question is about sort of resistance from the nursing staff themselves, or so from a cultural point of view. We actually held. Say again? That's how I've read it. Yes. Okay. Yes. So actually, we held a workshop with the night nursing staff. We facilitated a workshop between the night nursing staff and the emergency department nursing staff. And we did this because in reality these people never meet face to face because of the type of work that they do, and also it's very difficult for them to attend workshops given the work that they do. And when we brought the two teams together, I must admit I was really blown away by how dedicated and how passionate the night nursing staff were about the work that they did. If you consider that we're literally asking these people to work permanently at night with patients who aren't known to them and can arrive on the day of requiring assistance. And I think, you know, in talking to them about culturally and organisationally how they felt about doing that work, I was really impressed by that cohort of people. You know, and if you put yourself in the position of thinking, would I want one of my relatives to be cared for by these people, there was just no question about it. But the other thing that came out of that session, it was a session where we were trying to think about how the emergency department could refer people to the night nursing service direct. And it was an opportunity for two sets of nursing staff to sit down and talk about the handling of these types of patients and the confidence that they would have in allocating this patient away from the emergency room to this community nurse who they have never met and who is working perhaps in a remote part of Leicestershire. And that built a huge bridge between the two services. And it's probably one of the things that sticks in my mind from this entire process. You know, as helpful and as insightful as the stakeholder workshops were, this additional session that we ran with those two nursing teams probably did more to make that pathway work than anything else that we did. And that was about the cultural exchange between the two groups of staff.
Great, thank you very much. Please do join us on the LinkedIn Simulation Health discussion where we can answer further of these questions. The slides and the recording will be up on our website. I know that Cheryl has said that she's happy to take questions and contacts, and please do look at the models online. So thank you very much indeed, Cheryl. Thank you to all of you, and have a great weekend.